Good morning, everybody. Welcome to this PIN webinar looking at the road safety of older people. So just a few housekeeping points before we start. So this event is being recorded and there will be an opportunity to ask our speakers questions, and we're going to hold Q&A sessions at the end of each block of presentations. So please, if we could ask you to use the Q&A box at the bottom of the Zoom screen, then we'll try and get as many of those to our presenters as we can. So reducing older people's road deaths on European roads. Why are we holding this webinar today? We know we have an aging population, and it's clear that the road safety policy has to adapt to the needs of this aging population, particularly finding a balance between safety and independence of older road users. So this morning, before we have a short break, I'm going to present the PIN report that we published just last week on the overall road safety situation of older people on our roads. And then we've got two presentations focusing more generally on older road users and the implications of policy decisions such as age-based testing of car driving license holders, something that we know is being discussed at the European level and also nationally in a lot of countries. And we're going to then have a short break, and then we'll focus more on different road users. So the safety of older pedestrians, the safety of older cyclists, as well as the role of that public transport can play in the road safety of older people. So before we go to the presentations, I'm very pleased to have some welcome words from Joost Segers from Toyota Motor Europe. They are a partner in the PIN program. We're very grateful for them for their support. So I give the floor to Joost for a few welcome words.
Thank you very much, Jenny. So good morning, everybody. And first of all, quick introduction. My name is Joost Segers. I'm responsible for social impact at Toyota Motor Europe. And I'm very grateful to be here and be able to say a few words to welcome you all to this PIN conference today. And before I go further, also, so I don't forget, I'd like to thank all of you for your efforts and dedication to improving road safety and literally saving lives. Our global mission of producing happiness for all just can't be achieved if we can't provide safe mobility solutions. And that's why we're constantly working on initiatives to improve traffic safety. And we also have the ambition to reduce fatalities from traffic accidents down to zero. We can't do this alone. We need a combination of safe products, safe use, and safe infrastructure. And so we need partners to work with to continuously improve safety for all the road users. And that's why we are super privileged and happy to have been a partner with ETSC for 17, I think over 17 years, and have had the chance to support this very crucial agenda. Just a slide on coming to today's topic, reducing older people's deaths on European roads. Here are some examples of what we have been doing. You may have heard of Toyota's Total Human Model for Safety, or THUMS, which is used around the world by many researchers and engineers. It's one of the more advanced systems, we like to think. And it's also made available for free, by the way, since January 2021. But within this model of THUMS, also a version has been developed focusing on older people, because obviously in accidents, the way we tune restraint systems like seat belts and airbags obviously have to be adapted for lower resistance of older people who can sometimes sustain lower force and acceleration levels compared to younger occupants. So we have a specific model for that. In addition, we also have identified that older drivers are not just more fragile, but also need better protection, but also that they need support as being the driver sometimes. And some of the technology that we rolled out since then targets the lower agility or speeds of perception and higher risk of vehicle operation errors that can occur with older drivers, but are obviously helpful for everybody. Some examples are the rear cross traffic alert system, which helps avoid accidents when reversing, or brake override systems to suppress unintended acceleration, or the parking support brake system to help avoiding impacts to stationary objects. And then in addition, a pre-crash system, which augments that system to also be able to detect and reduce the risk of hitting pedestrians when reversing. Finally, to close, I'd just like to say that as we move from a car to a mobility company, our safety philosophy remains, and we count on your continued support and these kind of activities to continue to develop safe mobility for all. So thank you very much, and thank you very much, and we look forward to the rest of the conference. Thank you.
Thank you, Joost. Thank you to Toyota for your support of the PIN program.
Thank you.
So to start, we thought it would be an idea to present the PIN report that we published last year to give a sort of overall view of the road safety situation regarding older people. So I'm going to present that PIN report now. I just share my screen. So this is a PIN report that we published just last week, so it's very much hot off the press. I should perhaps say a little bit first about the PIN program in case people are not familiar with it. So the PIN program stands for the Road Safety Performance Index Program. It's a project in which we benchmark the road safety performance of 32 countries. So we have the 27 EU member states, and then also the UK, Norway, Switzerland, Israel, and the Republic of Serbia. And we have one person in each of those 32 countries who provide us with the data and the insights from their own countries into the road safety situation. We also have a small steering group who guides the overall direction. And every year we publish 3 reports. So we publish an annual report in June, which really looks at the very sort of overall situation regarding road deaths and serious injuries, particularly looking at the progress towards the EU target of reducing them both by 50% by 2030. And we also publish 2 thematic reports, like this one here on older people. Earlier in the year, we published one on power 2-wheelers. And we hold events such as this to try and raise awareness of the different topics and the findings that we find. Along the bottom there, you can see the sponsors of the PIN program. We're very grateful to them and all our PIN colleagues for their support. So this is, as I say, a report we published just last week. And what did we find? We found that over 5,400 older people, so we're looking at people over the age of 65, were killed in the EU in 2021. In the middle there, you can see a chart looking at how road mortality, so road deaths per million population, how this has sort of been progressing, reducing over the last 10 years. And we can see that it's reducing more or less at the same rate as the mortality of the rest of the population. Perhaps quite notable in that chart is the impact of the COVID pandemic there from 2019 to 2020. I should perhaps say one word about the sort of trends that we see and will present. And we know that obviously the years when the COVID pandemic hit had a large impact on traffic volumes and sort of mobility patterns. And we acknowledge those, but we took a decision within the PIN programme not to make any corrections for them. So any trends that you see, the data is as it is, and we have to bear obviously the impact of COVID in mind. If we look here, the road mortality, so the road deaths per million population in each of the PIN countries, we can see that there's quite a wide variety, in fact, a factor of 4 between the lowest road mortality rate and the highest. But it is important to know that road mortality, when you're looking at a particular section of the population, can be influenced by a number of factors, including the transport mode and also the sort of average life expectancy in a country. So it's important to bear that in mind. Also, maybe quite interesting when you're looking at the road mortality of a population, within that population band, so the 65 years and over, in fact, the mortality varies quite a lot. And we found that for those aged 65 to 74, the average road mortality was 50. For those aged 75 to 84, the average road mortality was 72. But for those over the age of 85, the average road mortality is 118. So that's quite a big range, from 50 in the younger portion to 118 in the higher section of the population. So if we look here at the average annual reduction in the level of road mortality of older people, so the first chart you saw was sort of relative change. So here we can see how they've been changing every year on average. And we can see that on average, they've reduced every year by 3% the road mortality of older people in the countries. What we did find when we developed this graph was we could see that from the annual report that we published in June, that actually there were similarities in the countries here that have made significant progress in reducing the road mortality of older people, had also made significant progress in reducing overall road mortality. But thinking of countries like Lithuania, Poland, which won the PIN award earlier in June, to a certain extent also Estonia, these countries have made significant progress here in older people's road mortality reductions, but also in overall. So it goes to show that if you make efforts to reduce overall road mortality, you're going to boost those efforts for older people as well. So now we have some data here looking at the road user groups. Again, across the PIN countries, the proportions of those older people killed and which method of transport they were using. And we found that on average, the EU average, 49% of the people killed were either pedestrians or cyclists, and 39% were car drivers or passengers. But obviously there's a great variety here. We've ranked these countries by the proportion of pedestrians and cyclists, and you can see there's a big difference within the countries. Perhaps particularly if you look at somewhere like the Netherlands, where they cycle a lot, there's a higher proportion of cyclists killed. In fact, that proportion in the Netherlands is 46%, whereas the EU average is 16%. But obviously in the Netherlands, they cycle a lot. It's easily explained. Next, we look at the gender perspective, and here I think the differences between males and females are quite striking. Older men tend to be killed as car drivers. Older women tend to be killed as pedestrians. And I think you can also see from this graph the risk of death associated with a change in modal use. So with increasing age, older people tend to be killed as pedestrians. And one of the sort of starkest points we found from this report, that there's 1 out of 2 older women are killed as pedestrians. So I think there's an important message there for policymakers to take into account. So the last graph data that I wanted to share with you today is this collision matrix. So this shows us the collisions that are taking place in which older people are killed on our roads. And again, 46% of older people are killed in collision with a car. 60% of those are pedestrians or cyclists, and the EU average for that is actually 33% for the rest of the population, sorry. So 60% of those killed in a collision with cars are pedestrians or cyclists. And this, it kind of shows what's happening and why people are being killed. So that's the data, that's the findings, that's what we found when we looked at the data. But what can we do to improve that situation? What measures can we take to reduce those figures even further? And we're going to hear a lot today from a lot of experts about the different topics, which is great. But we looked at issues like fitness to drive, the impact of age-based medical testing. It's something that's being discussed. We know at the EU level, also nationally, a lot of countries are looking at the situation regarding fitness to drive and medical testing. Older people are more frail. We know they are vulnerable, more vulnerable in collisions. But we also found that the age-based medical testing wasn't found to reduce the number of severe collisions. Also, we present data in our report which shows that other medical conditions have a bigger impact on fitness to drive, and they can obviously occur at any stage in our lives. So we look at that situation of age-based testing carefully, and we'll hear more from Desmond and Julia about that later on. Then we also looked at the safety of older cyclists, particularly the rise in the use of e-bikes. Again, we're going to hear later on from Katja about some of the data that they found in Germany, the situation there, and what they're trying to do to improve the safety of older cyclists in Germany. We obviously, the health benefits, we know that the health benefits of cycling outweigh the risks, but we must, if we're going to encourage more people to cycle, more older people to cycle, then we must also work on improving the infrastructure and the places that they do cycle. So that's something we're very clear about in our report, that more has to be done to protect them. Likewise, pedestrian safety. Older people, as they stop driving, they become more pedestrians, more likely to become pedestrians. But we highlight the issue here of pedestrian falls. So we know that pedestrian falls happen. They're not included in the EU definition of a road death, but they are happening. And we found reports from the Netherlands that unlike pedestrians killed on the roads, which is sort of on a downward trend, the number of pedestrian falls is actually rising. So we need to look at that topic of pedestrian falls, and Jenny from Sweden is going to be telling us about how they do that in Sweden later on. Public transport, again, has a really big role to play. We found in our report that a lot of countries offer older people reductions for riding on public transport. They really want to encourage it, but it has to be safe for them. And we're going to hear again from Transport for London to see how they are working on that. Infrastructure that is safe for all road users, for older people, sorry, will be safer for all road users. So what can we do to make sure that our roads are safe, that our pedestrian crossings are clear, are adapted to perhaps the walking speed of an older person? How can we make sure that cycling infrastructure, pavements are flat and that they are well maintained? All these things would much improve the safety of older people, but also benefit all road users. And then lastly, we looked also at vehicle technologies. There's a lot of technologies entering into our cars. There's not a great deal of research about the impact of them on older people. There are some that we know can benefit them, but we also talk about in our report about how some of them can increase the workload perhaps of an older driver. So should we perhaps do more research on how these technologies impact older people? We think there's merit in that. So that's the report. We also include in our PIN reports many recommendations. I know there are a lot of them. I've just picked out a few of them here to talk about. I've spoken about a lot of them already: improving the quality, access to ease of use of public transport, slower speeds. We know that slower speeds can much reduce the impact of a collision. So 30-kilometer zones would impact everybody, but particularly the more fragile older population. Improving that infrastructure for pedestrians and cyclists, making sure that things are clear and adapted to their needs. And this very much focusing on pedestrians, the recommendation to construct very highly visible, recognizable, uniform pedestrian crossings that are clear for everyone using them, but particularly older pedestrians. So thank you very much. You can find our PIN report on the website just there, yeah, hopefully you can read that at your leisure. So that's the PIN report. As I say, there's a chance to ask questions at the end of after the next two presentations. So please feel free to add them to the Q&A box. But for now, I'm going to give the floor to Desmond O'Neill. Desmond is a professor in medical gerontology at Trinity College Dublin. He's also chair of the Irish Society for Physicians in Geriatric Medicine. And he's going to talk today, I think, more about car drivers, age-based medical fitness to drive testing, and his experiences and the research that he's done in those topics. So Desmond, I'll give the floor to you. Thank you very much.
Beg your pardon. Thank you very much. And look, delighted to be here. It's been great to work with ETSC, and ETSC is a really important focus and force for improving road safety in Europe. And indeed, what's interesting is I've found in my international work is that the work of the ETSC actually is also influential in a global sense. So what's very welcome, just a little background myself as well. I've been involved with what's called traffic medicine, which I'll briefly talk about, for 30 years now, and have been involved with the WHO, the US Transportation Research Board, the UK House of Lords, around advice around medical fitness to drive, starting originally with older drivers, but actually having worked out that older drivers were pretty much the safest group of drivers on the road, broadening out into other areas, in particular interest recently in tackling alcohol, which is the great silent issue in medical fitness to drive, and it is a medical condition. So very much welcome the updated PIN report. And I think the key message is to keep looking at what are the important messages in the report. And where we see is that over half of older road deaths are vulnerable road users, a third are pedestrians, 16% cyclists, and 1 in 2 pedestrians. So what does that mean in terms of then drivers? Because there's a lot of misguided thinking and misguided approaches currently, which are certainly of contemporary urgency because of recent moves by the European Commission, which generally has been well informed on driving, but this seems to have a bit of a blind spot about older drivers. So the key messages today are older drivers are the safest group of drivers. Indeed, we could start usefully perhaps using some of the strategies that they use in teaching younger drivers. And I'm delighted to say the Australians have finally cottoned on to this and are using the insights of older truck drivers. They've analysed them and they've put them into the courses for younger truck drivers. Older drivers are smart drivers and handle prudently the medical conditions they have. The second thing is don't drive them off the road and turn them into these 55%, 1/3, 16% by inappropriate screening measures, which are ineffective and harmful. And this is a real challenge to get across to people because of perhaps us not developing our insights into aging as fast as we could. Our populations have grown older and we're holding on to old-fashioned ideas. But the third piece, and again, the European Commission's own research has suggested this, it's really important to make sure that your doctor, if you have stroke or Alzheimer's or Parkinson's, knows how to advise you properly, and that your doctor has traffic medicine. And we've shown that in postgraduate training in Europe, it still remains an area that's not adequately provided to doctors, because with right advice, you can continue driving for safely for somewhat longer probably than people might have thought. And we know that it reduces, giving good advice reduces crashes and fatalities. The key concern is that in the most recent directive, which has very many positive things in it, unfortunately, it still seems to have this concern that older drivers are somehow dangerous and that they're putting in reduced periodicity from 70 in order to apply an increased frequency of medical checks or other specific measures, including refresher courses. And for a general population and people who don't understand gerontology and the data, this seems, oh, well, these are people with medical conditions. Surely this makes sense. Unfortunately, the data really suggests the contrary. And this is the myth that won't die, that somehow or other, older drivers are more dangerous, and by screening them, we'll reduce crashes. In fact, what we know from around the world is that older drivers have effectively reducing and falling crash rates. And given their increased fragility, what's interesting is we see actually that their fatality rates are also declining, certainly in terms of the numbers. Now, there are often false, specious reports suggesting increased fatalities means there's more older drivers crashing. In fact, we've got an increasing population, so you've got to take it relative to the increase, and fragility is the key issue. So in fact, this is effectively a safe group of drivers, and we need to look at things like avoiding screening them, but perhaps in-car safety measures as well. So why have we persisted in some countries in having this screening, which has leached into the Commission? And the first thing is the failure to have adequate expert medical advisory input into driver licensing systems. So in some countries in Europe, this is relatively sophisticated. In some, it's relatively absent. And in terms of the European Commission, as I'll talk later, while for individual medical conditions, they've developed good working groups, they have not got a consistent working group to update the advice. The second thing is the fallacy of increased crashes per mile. We know that this is an artifact of low mileage, and when you control for it, actually older people are not only no worse, but actually there's a trend towards them being better than younger drivers with low mileage. And lastly, fragility and in-car safety measures. And in-car safety measures are designed for the 70-kilogram, 30-year-old male, and not for the 75-year-old with fragile bones, with a shrunken brain, which then can rattle around effectively and damage itself against the walls of the skull and eye, and increase with airbag injuries among older people. So we see increased brain and eye injuries, not at all what we want to see. So what doesn't work is routine medical vision or psychological examinations. We've seen this in Denmark, where they tried putting in a memory test, no reduction in road deaths. In cars, an increase in pedestrian deaths. The thinking being that we're driving older people out of their cars because they don't like doing this test. And similarly, in a comparison of Finland and Sweden, and similarly in a comparison of Victoria with other Australian states. So increased deaths in vulnerable road users, no improvement in in-car deaths. Older driver retraining sounds like a great idea. It's not. It actually increases confidence, and there's an increase generally in minor crashes, but it's a waste and a diversion of resources. And lastly, relying only on lay driver licensing agency personnel. And I have to say, having been for a while attending the EU Commission on Driver Licensing, their Committee on Driver Licensing, some countries clearly had significant medical input, but some didn't. But here's the important message: what does work? Good guidelines for the clinicians and the public. And we've done surveys of the public who are still unaware of the possibilities, opportunities, and limitations of medical fitness to drive. Training in basic traffic medicine for doctors and other healthcare workers, information resources for the general public, routine itemized self-declaration of relevant medical conditions at license application and renewal, a framework for on-road assessments to support clinical judgment, and restricted license is very helpful. Restricted licenses in terms of limitation of speed, of distance, and in particular, daytime driving. So these are the things that work, and these are the things we should be promoting. And I have a sense that the ETSC certainly understands these things. And what we could reduce this down to is don't screen whole populations. It costs, it's ineffective, it's harmful. But do provide appropriate advice in the clinical setting where you or I will present with our Parkinson's, with our stroke, with our dementia, and we know this works. So one of the key elements of it is a thing called traffic medicine, which is still relatively niche, and it's something we do need to develop further. It's a specialism embracing all those disciplines, techniques, and methods aimed at reducing death and injury inflicted by traffic crashes, but it also is enabling and rehabilitative. And this is the big change that's happened in the last 20 or so years in trying to ensure that transport mobility is not hampered or rendered unsafe by remediable illness or functional loss. And indeed, one of the things we've heard about and we'll be hearing about is that if you're not in your car, an increase in single pedestrian accidents or people who are falling outside. Okay. It's quite complex because it involves not only medicine, but also the allied professions, a field called traffic psychology, transportation policy, road safety. And indeed, it's a big health risk potentially for people is not only that you become a vulnerable road user and are killed as a pedestrian or a cyclist, but also that you might suffer from a thing called transport poverty, and whereby you can't get to health or you can't get to social or other issues. So does providing itemized advice work? And the answer is yes. A big study in Canada in 2012, published in the most prestigious medical journal, New England Journal of Medicine, showed that if people came to an emergency department, they had a medical condition that was relevant to driving, and you advised them, you found an almost halving in the annual rate of crashes per 1,000 patients. But there's an important sub-message for older people. So blue is what happened before they gave the advice, and it's the amount of crashes per year. Red is after it. But look what we see with the older people, even before they were advising them, even though they had the most medical conditions, they had the lowest crash rate. And if you give medical advice, that floored out. But look what happened in the other areas. Most of the reduction in providing medical fitness to drive actually occurs in younger populations. And actually, one of the ironies of the focus on older drivers and medical fitness to drive is we've ended up producing guidelines that work for all ages. And this clear vision is the key, is that it cannot be all about safety. There are major benefits to increased mobility and avoiding traffic poverty, transport poverty. So shared responsibilities is key. And very often in some countries, it seems to be very much left back to the National Driver Licensing Agency, whichever it is. So it's really important, and we're fortunate in Ireland that a legal precedent has been set that drivers have responsibility for their own medical fitness to drive. Ideally, they will be informed. Healthcare professionals as well, and not just doctors, alcohol counselors, emergency department nurses. If you see it, you own it. But also the driver licensing and authority. That's the Irish one. But ideally, we understand that each of these players has a responsibility, and we set up a system to do that. But they all need to be supported. Now, Europe has made a good start, and what's fascinating in the United States, which is normally the engine of change and where we get guidelines and that sort of thing, is that medical fitness to drive has been sent back to the States. It's not federal. It is federal for truck drivers, so they do have some regulations. So it's really a bit of a vacuum in the United States medical fitness to drive compared to Europe, where the European Commission, largely on the basis of freedom of mobility and the ability to work, set up some general directives, and by and large, the evidence in them was very good for the time. But what's interesting is medicine does move on, healthcare moves on in terms of research, and one of the things we'll come to is the need to renew the information in these guidelines, and how do we do that? And what the European directives have done is within a year, each of these needs to be put into national regulations and law. And what they've allowed us to do is move forwards and put these into high quality guidelines. So these are the Irish guidelines. Sláinte agus Tamont is the Irish phrase for health and driving. Medical fitness to drive guidelines. If you Google our NDLS and look for medical fitness to drive guidelines, you'll find these renewed every year with significant emphasis on the evidence base for our decisions, and each year reviewed by an outside expert. And what we've shown is by implementing guidelines, and we're very grateful for the 2009 directive prompting this, setting up guidelines and a training program, is we found that over 70% of family doctors felt confident in assessing medical fitness to drive, and over 80% were aware of the guidelines. Among that, and in other countries or jurisdictions, we find awareness of medical fitness to drive guidelines down in the 20%. So this is a relatively modest program, effectively 2 whole-time equivalents, but positive support from the National Driver Licensing Agency and voluntarily from the medical professions. And the good news is we can bring a good news message to the medical professions that if in your area of practice you come across somebody who is lacking in fitness, or their medications are inappropriate, or their cataracts, you can actually improve their road safety and their mobility. And Adina, happy to provide references on the impact of this. So this doesn't work on a whole population basis, but it works in a clinical basis. And this has really been something that's allowed us bring the medical profession on board in the countries where we have set up a framework to bring them on board. So what's the process we're recommending? That the doctor, whether it's a GP or a specialist, or you may get a second opinion, supported by guidelines, good guidelines, and access to training, makes a decision. You might use an occupational therapist, or ergotherapy, it's called in some European countries. You may need an on-road assessment. But the key thing is a low threshold for a second opinion. So if you're a family doctor and they've got Parkinson's, you'll ask, and you could feel you can ask a neurologist or a geriatrician. You advise the driver. The driver will need to inform the Department of Motor Vehicles for certain conditions. They may request a medical report, and there's a process for the non-compliant and the hazardous. because everybody looks to this. But what about if somebody isn't complying? Well, then you put in a process for the non-compliant and the hazardous. And most people are compliant. And older people tend to be more altruistic and more rule abiding than younger populations. Why the patient's own doctor is key and not some third party? First of all, because you are more likely, particularly as an older person, to have multiple conditions, multi-morbidity. So your doctor is the person who's best able to say, well, actually, it's not the blood pressure that matters here. And in fact, the diabetes is well controlled, but actually you do have a problem with Parkinson's or your previous stroke. The second thing is the key thing in how people deal with their medical conditions is prudence, how smart they are in understanding the impact of their behavior on themselves and other people. And generally, doctors have a good idea who's prudent and who's not prudent, who you might then have a higher level of suspicion. Encourage a second opinion and further assessment, and guidelines and training protect. And one of the helpful things is it's a widely known in medicine that if you don't use a guideline, you're more likely to make a mistake and be sued or be brought to the courts than if you do use guidelines. There are three sets of main conditions we train people to look out for: suddenly disabling, such as syncope, which is loss of consciousness, epilepsy, cardio defibrillators. Now, these are the obvious ones, and they're the ones that have the longest history in being inserted into medical fitness to drive. Then came the physical constraints. So Parkinson's or hemiplegia is weakness on one side from a stroke, vision. And again, we're clearer there. But the really important ones going into the future are impaired self-regulation due to imprudence, psychiatric illness, alcohol and substance use, and cognitive impairment, such as early stage dementia. And these are the areas where we need to train people up. But also then raising awareness in the general public. And this is an initiative in Ireland whereby we developed a series of leaflets so that the general population, and it's on the driver licensing application and renewal site, we offer them to the various medical specialties so that we get a more informed general public. I think a key element is self-declaration at application and renewal. And this is, again, when people don't understand behavior and statistics, they say, but people could lie. But in fact, if you have an itemized yes, no of 27 relevant medical conditions, and if yes, a medical certificate, this generally works well. And it's important to back this up to make it a statutory offence to misdeclare. Now, there are certain areas, the big neglected area of this course, alcohol and substance use, people tend not to declare, but that's, I think, a developmental work for another decade or so, bringing a whole load of people on board as to what to do with alcohol and substance use. And within the medical profession, what you'll be hopefully reassured to hear is there's a big movement now to improve the quality of national level guidelines on driving with medical illness. This is a group from Canada, Australia, the United Kingdom, the US, which is working to improve medical fitness to drive guidelines. And in fact, what we found in this study hugely has informed, for example, the Irish medical fitness to drive guidelines, showing that you've got the evidence behind what you're saying and using outside scrutiny for quality. So nearly through now, there's two important movements which I think have helped. CIECA, you may be aware, is the Association of Driver Testers and Assessing, and they helpfully brought together a report on medical fitness to drive, which gave useful advice to the Commission. Again, I'm not sure the Commission heard them on the retesting, so hopefully the Commission will rethink that part. But what they felt is that apart from some useful advice on medical fitness to drive, is we really need a European Union clearinghouse on the fast emerging evidence on medical fitness to drive, which generally supports a more liberal but structured approach, and that there should be a permanent European Commission working group, expert working group on traffic medicine. The other area which I hope you can turn to is the very influential Monash University influence of chronic illness on crash involvement motor vehicle drivers, which is reassuring in that the crash risk from most medical conditions, when they're supervised, is relatively low. And in fact, the key thing almost is to make sure is that people are not inappropriately penalized. And what this can work through by having a good, an international approach is you can then develop a very pragmatic and useful guideline for example, a key emerging condition, driving and dementia. And again, no evidence that driving with dementia poses a public health hazard, and reassuring evidence from Quebec and California that if a driver with dementia declares themselves to the driver licensing agency, their crash risk is halved. Now, not everybody declares themselves, but it shows that if you have a framework, it can help. So there is evidence out there to help you. So what I would recommend, and I've recommended to the ETSC in just some of our discussions around this, is that perhaps this is the moment for us to develop a platform to engage with European medical organizations. And that's probably the key thing, rather than individual national ones, is to develop traffic medicine education and guidelines in their areas of practice. And we are beginning to see this in certain areas, but this is really the key element. The second thing is to develop European and national expert medical advisory boards to support national driver licensing agencies and the European Commission. And lastly, I think to engage with older people's advocacy to promote effective strategies. And again, it's important this is done early. And if there is a salutary example, the AARP, the American major advocacy organization, actually got off on the wrong foot here, and over 20 years ago started promoting retraining programs for older drivers that actually worryingly have been shown to be ineffective and possibly to a minor degree harmful. So very grateful for the opportunity to speak here this morning. Happy to take questions and queries, or indeed to email me, doneill@tcd.ie, because this is an important area for all of us. Happily, we're all growing older. Europe has generally positive, healthy life expectancy for older people. So rather than older people, we should talk about us as we age. And the key message is, again, older drivers are the safest group of drivers, must not be demonized. Don't drive them off the road by inappropriate screening measures, which are ineffective and harmful, and develop a framework to support traffic medicine, better advice for the public, that will allow us all to have better mobility in our own future older lives, and for those who we care for in our families. Thank you.
Thank you very much, Desmond. A very comprehensive overview of the situation, some of the key elements that we can think about if we're sort of moving away from this age-based testing idea. So a lot of food for thought. Thank you very much. So I'm going to give the floor now. So the opportunities after the next speaker to ask questions of myself, Desmond, and Julia. But I'm going to give the floor now to Julia Wadou. So she is the policy manager, healthy aging and accessibility at Age Platform Europe, which is an NGO based here in Brussels, giving a voice to older people. So I give the floor to Julia.
Good morning. Thanks a lot, Jenny. So I'll share my screen like the other speakers so that you can see the presentation. I'm also delighted to be on board today and to receive all that information of this wonderful report that has been put together by ETSC. I think we should think about recruiting Desmond actually as a part of our self-advocates, because he's done my job actually. So let me introduce first of all maybe Age Platform Europe. I'm just trying to find out who we are first, so that you understand from where I speak. So we are an organization, an umbrella organization based in Brussels. We do represent all the people in Europe since 2001, and our members are basically organization of all the people or organization working for all the people. And the point is really to advocate for the rights of all the people. The mission and the vision that we have is actually we do celebrate longevity, as Desmond was saying. Well, actually, we have to be happy actually that we are all aging. It's somehow a great result. We raise all the people's voices and claim for participation. So this is why self-advocacy is really critical to us, you know, making sure that we do involve all the people and we listen to them. And the ultimate goal that we have is actually to seek for age equality. So we combat ageism, we promote human rights throughout the life course, and we try to reduce inequalities along the life course as well. I wanted to share some basic statistics about old age. And I think I need to start making a disclaimer probably because this is a question that people often ask us. What kind of age group do you represent actually? You know, by when do you define older age? And it's a difficult question actually. So we have moved away from trying to define it from a chronological perspective because it's actually not really easy. It doesn't pay tribute to the diversity of all the people as well. And depending on the topic you're speaking about, you have actually to adapt as well. And this is really important. So basically today you have seen that the ETSC report is taking all the people from the age of 65. But Age Platform Europe is also working on discrimination in the employment world. So basically, in that case, we have to take a younger proportion of all the people. Otherwise, you know, we don't really look at the issue of discrimination in employment. So this is why it's sometimes difficult to just stick to one group and to make it workable for everyone. Well, still, when it comes to statistics, it's of course quite difficult also to completely get out of chronological age because it's basically quite easy to use. This graph is actually just showing you that, well, the proportion of older people is increasing in the EU. I mean, this is probably not something new to you, but what is the most important, and I think this is still something that people don't figure out really good, is the fact that the proportion of 80 plus is actually the group of population that is growing the fastest. And this is really something important as well, because it means that when we speak about older people, we have to think about different age groups and the fact that we have as well, you know, this part of population that is growing fast. Another dimension that is really important to us as well is the gender dimension. This is something that Jenny has clearly highlighted in the results of the ETSC PIN report. And it's indeed very important because it has an impact in terms of healthy life year expectancy. So while the healthy life year expectancy is more or less equal for men and women, the life expectancy is much longer for women, and therefore you have also a number of lives lived by older women in let's say bad health, which is longer than for men. So it's important because it has an impact as well. It will have an impact in the way you use mobility as well and the different means. The gender perspective is also very critical because it has an impact in terms of poverty, income, and the geographical perspective as well. You have lots of older women living in rural areas as well. So again, it will have an impact in terms of mobility and what kind of transport or modes you will use actually. And last but not least, the geographical dimension, which is also very important because, well, you have actually, if you look at the statistics, you will see that in comparison to the total EU population, the number of older people living in rural area is quite high actually. And again, it has an impact, you know. In that case, of course, the access to public transport might be lower, might be more difficult. So relying on your driving license and on your car might be very critical to access services and specifically essential services, you know, like buying your food, going to the medical doctors if you need. So this is also very critical and important to bear in mind. Well, of course, I'm not going to into the details of all the little groups and different perspectives. There are many others, but these are the most important, I think. Beyond the statistics, I would like to touch upon what is called ageism as well, because it's not really a new notion, but let's say it's raising in terms of attention, but it's not that well understood and well known. And I think it's quite of a critical dimension to understand the position that we take actually in relation to all the drivers as well. So let me first give you a definition. This is actually the definition that is given by the World Health Organization in a global report on ageism that has been published in 2021, so it's quite recent. And basically, they refer to ageism as the way we think, so the stereotypes we may have, the way we feel, the prejudice that we may do, and the acts, the discrimination we can induce towards others or ourselves based on age. So it means that it concerns, of course, older people, but it might be vice versa for younger people as well. So it's quite important, but it's really all this discrimination that is linked to age. Ageism is harmful, actually, and the report of the WHO is showing quite well in all different areas why it is so. Of course, I will mainly focus on mobility and driving in our case today. And what I wanted to say that, well, actually, if you look at the report, they make clear that stereotype consistent behavior can be triggered through what is non-stereotype threats. And what happens there is that people tend to underperform a task due to worries about confirming a negative stereotype. So basically, because you tend to say that older people are less safe when they drive, or they have more issues in terms of medical conditions, or they might have less easy way of handling with their body, then they tend to actually indeed, have this type of behavior simply because they have internalized, this type of stereotypes, which are not correlated by the figures as shown by Desmond previously. So it's really important because it means as well that they may do less well on driving tests or cognitive tests simply because of anxiety, actually. So it's not because their intrinsic capacity are less good. It's just because they are stressed about this. And this is, then it can induce related consequences, which are quite impactful and difficult. So this is really something important. And we have to actually look at that carefully to make sure that we do not take decisions that will have harmful impact, as Desmond said earlier as well. And when it comes to ageism, we also want to make sure that actually we look clearly at the wording that we are using, but also the pictures. Actually, I think the nice pictures shown by Desmond was quite interesting on that way. And for instance, just to give you a simple example, on our side, we are trying to push the European Commission, making clear that we should use better older drivers, older users, instead of elderly drivers, elderly users, simply because elderly tends to include a dimension that is stereotyping, actually, and that makes people thinking in a way that might not be exactly the right way, or let's say the way that is encompassing everyone. So all the people, all the drivers, all the users is neutral somehow. It gives just what we need. Coming to mobility knowledge. So why mobility is critical for older people? So I mean, I suspect it's quite obvious that older people are heterogeneous, and the mobility can be critical for different reasons. So this is where we have also to bear in mind the diversity of older people. Speaking with our members, what comes out is what is really important for them is the accessibility, the availability, the affordability of public transport. This is really critical to them because it's a way to be socially connected. The accessibility of the outdoor environment, how much you can have benches in the streets, how safe cross sections are, how to make sure that the pavement is safe enough as well. And the possibility to drive is also something that is quite important to them. And actually, it's quite impressive to see that with the new proposal of the European Commission on the EU driving licenses, we have quite a number of our members who are very supportive, very active. Sometimes it's difficult to mobilize them on some EU legislative processes, but for that one, believe me, they are really ready to battle for something that would be much better. So this is really something important. Mobility is also very important simply because, it allows people to do things they need to do, they love to do around their house, accessing shops, services, facilities in the communities, to participate into social and cultural activities, And if they are not able to move around, their social networks will be affected, and the community will actually lose the contribution of all the people who might be informal carers, who might be grandparents supporting children, who might be volunteers in club sports, and whatever kind of other types of activities. So this is really important, because the need for additional resources to support all the people will be then needed as well. You will have to do much more to support them if you don't give them the possibility to be mobile and to be socially connected. So this is also a counter process that is important. And a key determinant of declines in mobility in societies like ours, who are still very much dependent on automobile, is ceasing to drive in older age. So it's really critical in that way, and it can have very bad consequences in terms of inclusion and participation, and therefore autonomy, dignity. So I don't need to go into that details. How can we support all the drivers? Well, obviously, Desmond has provided with plenty of different options, which are really important. And I think they are very important simply because they are evidence-based, and this is what we need. So you can also look at the World Report on Aging and Health, which has been published in 2015. And actually, there's a number of information related to older drivers. So that's interesting, because it's part of public health, actually. You know, mobility is part of it. So that's really important. So basically, building cognitive capacities of people, it will have an impact on their capacity to drive better as well. Increasing physical activity sounds strange, but you know, the more active you are physically, the easier it will be as well to use your car, to be mobile into it, and probably to have the good reactions as well. So these are things which are really important. And the report of the WHO by that time was already mentioning the fact that we have to be careful when judging to withdraw a driving license, because it can have indeed a strong impact on the autonomy of people. So this is really interesting, because it shows that this is something that is taken into account as well from this perspective at international level. I just wanted to share as well a little bit of information that I gathered from my members recently when we had a session actually on mobility, and we spoke as well about all the pedestrians and cyclists. So it's a little bit beyond the topic that was given to me, but I think it makes sense as well, because we've seen how much everything is connected. So that is really important. Our members are raising concerns about shared space, which are more and more used, actually, especially in our cities. So not to say that they shouldn't be used, but just making sure that they are clear from obstruction, that it's a bit easier to use, probably that the signage is done in a way that will help everyone to move safely as well, and that the more vulnerable won't be put at risk. They have more and more issues regarding e-scooter, e-bikes as well. So indeed, there is a number of them are using them, but as pedestrians, they feel as well a bit unsafe, because those are very silent, but also because the speediness of these electric engines might be a bit difficult to tackle with. The accessibility of the outdoor environment, I was speaking about it already earlier. So the pavement, especially, Jenny mentioned the falls issue. I mean, this is probably something very, very important. And also the safe pedestrian crossing, having enough time actually to cross a road. I mean, you can just do a test, and sometimes it's really critical if you walk slower just to cross the street within the time limit that is given to pedestrians. And the volume and speed of road traffic, and I think this is also important, you know, because it's important to feel comfortable in that sense. And again, all these type of things, they will not only use older users. It's, I think, something really important for everyone to be safe enough. Then I just wanted to share the recommendation that we have on the driving license directive. So I was advised by Jenny to explain a little bit the context, because not everyone might be aware of what's going on. I mean, this is something that can be looked at very technical. But basically, well, in March of this year, so March 2023, the European Commission has proposed a revision of the driving license directive. This is the legal scheme that allows drivers to use their license in any of the 27 EU member states. So that is something quite important. It concerns both lay users, lay drivers, but also professional drivers. So it's a big package. The overall objective of the proposal of the European Commission is simply to reduce the number of deaths, ideally to go to 0 deaths on road and less accidents as well. And it contains ambitious measures. I don't deny that. But on our side, we do question some of the provision of the driving license directive. First of all, we have an issue which is not directly related to safety, but still I wanted to share it with you about digitalization, because actually the European Commission is pushing for a mobile driving license by default. And this is something that can, again, be quite difficult for a number of people, not only older people, actually, you know, it goes beyond the question of age. But this whole digitalization process means that not only your driving license will be digitalized, but that's probably the whole process to get your driving license or to renew it will be digitalized as well. And that might have an impact as well on a number of users. So this is something on which we want to be careful and make sure that it won't push away a number of people, while actually, you know, being digitalized has probably not a lot to do with the fact that you are able to drive or that you need to drive, actually. But beyond that, we have issues mainly with two provisions within the directive, which are linked to what we consider our ageist provisions. So the administrative validity of the driving license that will be limited from the age of 70. And in that case, I mean, it's not that we are advocating against age limits, whatever they are. You know, when there is evidence and there is a clear understanding why there is an age limit and that it makes sense, we totally agree that, you know, that can be used. But in that case, actually, there's no evidence, and we don't really understand why the European Commission has decided to put this age of 70, and that within the discussion in the European Parliament, it could be even worse. It's really something that we question. Desmond showed clearly that it has nothing actually to do with the possibility to drive, with your ability to drive, and that you have plenty of other measures to put in place. It will have a problematic impact. So it's something that we do question, that we would like to delete from the proposal of the European Commission, while making sure that actually, yeah, you do have measures all along the life course to support drivers and make sure that they are safe is really important. That is for sure. And within the directive, you also have an annex with a list of standards for physical and mental fitness for driving, which is quite long and detailed. And within that list of standards, there are still things which are quite unclear in terms of definitions. And we are a bit afraid on how they will be used, actually. So we would like as well to change a number of them, just to make sure that the whole annex will be useful and can be used properly as a tool. So these are really things which are worrying to us. We have a little victory somehow to highlight. I know that the Society of Gerontologists has issued a letter to the European Commission, and actually we took example on them, to be fully transparent, and we called on the UN independent experts for the rights of older people and the rights of persons with disabilities to also issue a letter to the European Commission to highlight actually the difficulties we have with the proposal, and the fact that there are some provisions which are actually inciting stigma and discrimination based on old age. So this is really something that we are quite happy with. The letter is now public, so it's something that can be used widely, and we just hope that the European Commission will answer to it, of course, and that it will play a role within the negotiation with the Council and the European Parliament as well during the whole process. So this was my last word, actually. Thanks a lot to everyone, and like Desmond, I'm happy to answer any questions. So back to you, Jenny.
Thank you very much, Julia. Again, a very comprehensive overview. Really interesting to see this idea of how stereotypes impact even driving and safety, and also that point you made about digitization, how even digitization can act as a barrier and negatively impact. So we're going to have some questions now with Julia and Desmond. So we've had a couple in from through the Q&A box, so thank you very much for being active there. So I'm going to read this one. It's for you, Desmond, asking, how do you see the balance between self-imposed restrictions and legally imposed restrictions? And there's the person is asking, for the legally imposed ones, we need objective fitness to drive decisions, and an automatically imposed restriction would be discriminatory. So I don't know, what do you see about that, self-restrictions and the sort of legally imposed ones?
Yeah, I think the answer here is around using research and data here. What we can see from the research is the most important thing is, and if we go back to the work group from Monash, is to get some sense of how risky a condition is in the general background, and then to tease out the elements that seem to suggest effective self-restriction. So, for example, we can see that, and I think the example I would give is that of declaring to the driver licensing agency, as we see in Quebec and California. But probably the really important thing, I think it's absolutely right here, is there really needs to be a kind of a very stringent level of evidence for any legal restriction. And I think there are some concerns that we're not, because we don't have a consistent working group for the European Commission, we're going to miss out on evolving evidence that suggests some conditions are perhaps more safe than we thought. So getting the balance right is really important. The legal restrictions should be as minimal as possible in a way, and to the greatest extent evidence-based, and incorporate what we know about effective maneuvers that older and all ages drivers with medical conditions undertake to reduce their risk.
Thank you very much. Another one that we've had through the books, I think probably applies to both Desmond and Julia, about what level of priority are governments giving into increasing older driver safety and sort of addressing older drivers. Have you seen an increase in activity? Are they doing enough? Could we do more? Julia, have you seen anything from your partner organizations?
Yeah, I don't have a picture for every country, to be honest, and it depends very much from a country to another. There is still there are still things to be done, for sure. I think in terms of raising awareness, making sure that people do get the information properly, and that the infrastructure is also done in a good way, that will support everyone. When I'm saying so, it's, we have to look beyond the older age group, I think, because it will have a positive impact for everyone. There is still a lot to be done. Your statistics are showing well as well, that in a number of countries there are still effort to be done, because the number of accidents are still quite high, and there is need to push on that side. But it's if I look among our members, yeah, probably the ones from the 1,000 country are quite active on these kind of topics. And maybe because it's going a bit better in the northern part of Europe, there are less people active in the area. There seems to be, let's say, maybe a bit happier about the way it's going on as well.
Great. Desmond, have you seen anything? I know Ireland did obviously that bit of work around the traffic medicine program and educating in the postgraduate degree. What's your overall impression from the work that you've been doing?
Well, some of the good news is that, well, we had medical screening at 70, and we recommended to be abolished. The government said they would do it in stages, so they've increased the age from 70 to 75. So that's certainly a positive. They've set up guidelines, training. They're working on formalizing the training of on-road driving assessors, something that hasn't been clarified in Europe generally. So, I mean, the issue here is that this is one of these unusual areas of neglect from a range of players that's only beginning to be filled now. And I think it probably, you know, one of the questions on the board is how did this ageism creep in to the Commission? And I think it's largely around not having a central focus of expertise. And that's one of the things we really need to develop. And that's why my recommendations back to the ETSC are around a focus on the medical profession in Europe and also the European Commission for a permanent working group of expert medical advice.
Right, thanks. Another question that we've had, I think maybe for you, Desmond, is there any studies showing how medical fitness checks can support maintenance of fitness to drive? So I think people being able to drive longer because they've had a medical check. Is there any support of that, if I understood correctly?
Well, I suppose we've really got to divide out here the routine medical screening check, and the answer there is no. That's not helpful for across the population. We're still looking for evidence around what actually happens in clinics in terms of advice given. But the New England, to a certain extent, you have to wonder in that the New England Journal of Medicine paper was so strong in reducing crashes by 45%. And I think the other really important piece and is Bernard Isaacs, the great gerontologist, said that if you design for the old, you include the young. If you design for the young, you exclude the old. There's actually valuable lessons for drivers across the life course arising out of the literature on older drivers, for those with diabetes, with a range of conditions. So there work does need to be done. I think hopefully, I think most of us were dismayed to see this appearing in the Commission directive. And I think it's important that we not only push back, but give to them the things that do help traffic safety. So it's not a question of being negative, it's a question of being positive and evidence-based.
Thanks. I wanted to draw on a question, a point that was made actually by Joost at the very beginning from Toyota about the sort of technologies that are coming into cars. And Julia, I wanted to ask, have you seen anything about the impact of those technologies in cars on older people? Have you seen anything around this? Because we found in our report that there wasn't actually a great deal of research. It was done quite in the early days and then not so much later on. So have you seen anything about the impact of the technologies, sort of going back also to that digitization aspect?
So actually, we have no research as well. I mean, and not even a proper feedback from our members on these kind of things. To be fully honest with you, what we discussed recently was more linked to because indeed, I mean, it means that these cars are smarter, and I think it helps a number of drivers, probably not only all the drivers, but a number of others. We probably have to see, who is able to afford these types of cars as well, and how much it plays a role in terms of divide within the population. But the other issue is also linked to the accessibility of these different tools and smart tools which are being used on boards. And there is quite I know that from the disability movement, there is a concern actually that a number of these new tools might not be accessible to everyone. So this is also something we have to bear in mind actually, because they are supposed to help a number of drivers who may have more difficulties, but actually they are not designed in a way that make them accessible, then it can have an impact, or let's say they might not be used in the right way or benefits as they should do. So I think there will be a great deal of making sure that we do involve, a right diversity of drivers when developing these type of things, to make sure that they are able to use them properly and to benefit from them as well.
Thank you. I think we've got time for one last question for you, Desmond. Asking about, you spoke about restrictions, and this person's picked up particularly about speed restrictions. I think you were also talking about not driving at night, you know, within a certain, these things are actually all possible within the directive, and it's something we looked at in a previous report about the extent to which these codes that you can put on driving licenses are used, and we found the data actually to be quite lacking. But so they're asking about speed restrictions, and asking you to expand a bit on that, and yeah.
Sure. Well, there is evidence. We published a paper in European Geriatric Medicine summarizing the evidence, and there's evidence that they work, and they may work for a range of reasons. It may be the very fact that vigilance is put on you and that you're categorized different in terms of the relationship, a kind of a form of an individual Hawthorne effect, the sort of thing we see in industry when workers are looked at. The limits are quite generous, but the fact that they're there at all actually is a signal. So it's 80 kilometers an hour, 80 kilometers distance. But the other thing we always say to doctors, you can, and other healthcare professionals, it's not just the what's written down in the restriction. You can write in your notes, you should not be pulling a caravan with your car, you know, with this mild cognitive impairment or mild dementia. So, and I think it's relatively clear in a court of law or insurance case that if your doctor had advised it, even if it's not in the European Commission guidelines and you'd gone against that, is that you, by and large, in terms of insurance and the law, you'll be on the wrong side of the law. So you can, there is evidence for effect of the restrictions, and you can add more as you see fit. And the people keep fretting a little bit about, but who's overseeing them and who's monitoring them? Well, A, you can put the restrictions on the license, but B, the evidence suggests that the thing in itself works, and it works under the same degree of supervision as any other restriction.
Great. Thank you very much. So we've run out of time, but I just want to say thank Julia and Desmond very much for both your presentations. We will make them, they've kindly agreed that we can make them available after the event, so we'll put them on our website. And thank you very much. But so now we'll have a quick break until about past, and then we'll be back to look at the safety of older cyclists, pedestrians, and the role of public transport. So thank you very much, and I'll see you in about 10 minutes. Bye-bye. So, welcome back, everybody. Thanks for staying online. So we've talked this first half of this morning, we've looked at predominantly at older car drivers, and now we're going to move to older pedestrians, older cyclists, and the role of public transport. So I'm really pleased to be able to welcome Dr. Katja Schleinitz. So she is from the organization's TÜV DEKRA in Germany, and she's an expert in the field of older cyclists, older road users, and particularly e-bikes. So she's going to tell us a bit about what she's found from her research into this topic, and some of what they're doing in Germany to try and improve the road safety of older cyclists in their country. So I'm going to give the floor to Katja. Thank you very much.
Thank you for this kind introduction, and I hope everybody can see my presentation. Yeah, I will talk about older cyclists and e-bike riders, and there's the question, what's same, what's different? At first, I have to mention that we have two different bikes, e-bikes in Germany. The first one are the pedelecs, which support up to 25 kilometers per hour. They are legally treated as conventional bicycles, and 99% of e-bikes sold in Germany are from this type. Another one are the S-pedelecs, which support up to 45 kilometers per hour. They are not allowed to use bicycle infrastructure. They need a helmet, a license plate, and you need a driver's license for motorcyclists. And I will talk most of the time about the pedelecs, which support up to 25 kilometers per hour, because they are the common type. At first, I show you some data from the German Ministry of Transport. In the figure, you can see that pedelec and bicycle crashes are increased in the last years. In 2014, there were about 2,000 pedelec crashes. In 2021, it increased to nearly about 17,000 crashes. And for the bicycles, it's a little bit different. We have a slight decrease from 60,000 to 76,000 to 67,000. But this was only the case in the last year, in 2021. And we have the problem that Germany has one of the highest death rates in the EU for cyclists. Therefore, it's a very interesting topic. And as you have seen, the pedelec crashes increased a lot in the last years, which is in line also with the market share. In 2012, we had about 1 million pedelecs on the road, and in 2021, there were nearly 10 million. And pedelecs are especially popular with older riders. So there raised road safety concerns, especially due to the higher speed and the higher weight of pedelecs. Now I will show you some data from our studies, or from studies from other colleagues. And at first, I will address the questions, are pedelec riders faster than cyclists? Because this was one of the concerns. And here you can see that is the data for the conventional cyclists, that most of the cyclists travel between 11 to 18 kilometers per hour in most of their trips. For the pedelec riders, it's nearly the same. Also, they are traveling most of their trips in this speed area, but we have also a lot of trips in higher speeds, or on higher speeds between 24 to 30 kilometers per hour. And for the S-pedelecs, it's totally different. They are very much faster. You can see this also in the mean speed, and we investigated this for different age groups. And we found that for the older riders, 65 years and older, they are, when they are riding a pedelec, they are also 1 kilometers per hour faster than the bicycle riders on average. Now I will show you some crash data. These are police reported crashes with personal injury with regard to gender and age distribution of the rider. You can see on the left side that the age distribution is nearly the same for both bicycle types. 2/3 of the riders are men. But for age, we found a huge difference between pedelecs and bicycles. Pedelec riders are nearly 20 to, or in 2021, 15 years older when they crashed compared to conventional cyclists. And you can also see that there is a decrease in the mean age in the last years, which means that the user groups of e-bikes changing. More younger people using e-bikes in the last years, also families with cargo e-bikes to transport their kids or something like that. And this is an ongoing trend, and I would expect that the mean age decrease in the next years as well. This is an investigation from the German accident research, and you can see the crash risk of pedelec riders and cyclists when they cause a crash. And they calculated the crash with a proportion of crashes, of personal injury per kilometers ridden, and it's a typical U-shape. The younger groups and the older groups have a higher risk. In blue are the pedelec riders, in gray are the conventional cyclists, and which is very interesting that the crash risk is especially high for e-bike riders in the younger age group, between 80 and 24 and between 25 to 33. And for the riders 80 years and older, but for the other older riders, it's nearly the same, or it's the same like for conventional cyclists. The problem is higher for the younger groups. But what are specific attributes of the accidents of pedelecs? You can see here the number of conflict partners. This is totally different between from the pedelec riders to conventional cyclists. For pedelec riders, we have a higher share of single accidents throughout all years since 2013. And this is also true for the older riders, 65 years and older. 26% of all accidents are single accidents for the pedelec riders and only 18% for the conventional cyclists. What's also different is the injury severity. You can see that for the pedelec riders, we have a higher share of crashes with fatal injury or serious injured people. It's for fatal injury, it's double as high as for the conventional cyclists. And this might be a problem because the user group is older, they are more vulnerable, and so there's a bias that they have more serious accidents. And we looked at the correlation between age and injury. You can see in this figure that the mean age for both bicycle types of fatal injured people is higher. That is very common. And also for the serious injured people, but for the pedelec riders, the mean age is higher compared to the conventional cyclists. And we analyzed, we did an analysis and controlling for age and gender and other factors, and we found that there is a higher chance of serious injuries for pedelec riders compared to cyclists, also when controlling for these other factors, which might be explained by, for example, the higher speeds and the higher weight of the pedelec. When a crash happened, then the chance is higher of a serious injury when you are riding a pedelec. What are typical scenarios and crash types? Most of the conflicts happened at intersections, which is comparable to cyclists. The most frequent type are turning into accidents, like in the picture. For the pedelec riders, studies showed that other road users underestimate their speed. That's a specific problem, and choose smaller gaps for turning. And the effect is more pronounced when the rider is an older one. The reason might be that there are visual effects. The pedaling frequency is lower when you are using a pedelec, but it's faster. You look slow, but you ride fast. And so the other road users underestimate the speed. And there are also some situational factors. For both bicycle types, we found more crashes in outside build-up areas, outside cities and villages. But for the pedelec riders, there are, but no, sorry, it was a mistake. For both bicycle types, we found more crashes inside build-up areas, in villages, in towns. But for pedelec riders, we found a higher proportion outside, which might be explained by the fact that they use the pedelec for different types of trips. They are using them more for leisure trips, not so often for commuting, but this might change in the next years when the user group changes. We found also that most of the crashes happen on carriageway in longitudinal traffic. And specific for e-bike or pedelec riders is that they have a higher share of crashes downhill compared to conventional cyclists. Maybe because they travel with higher speed when they are riding upwards, and then when they are riding downhill, they accelerate faster and due to the higher weight and reach higher speed, and then they lost the control of the vehicle. This was often found in other studies, that loss of control is one of the causes of the most frequent causes of pedelec crashes. And also in Germany, we found that rider failures and inappropriate speed are more often described as crash cause for pedelecs compared to cyclists. And the most frequent conflict partners are cars. That is not so surprising. What we did in Germany to help cyclists and pedelec riders, especially the older ones, we have specific trainings for older cyclists and pedelec riders, but more for older pedelec riders. They are, you can make it, these trainings in several institutions, in cycling courses or in cycling centers. And for both types, we need an expansion of the bicycle infrastructure. We have campaigns to wear a helmet when you are cycling, and to use also retroreflective clothes like vests or helmet covers, so you can be seen, especially in this season when it's cold and dark outside. And so you can, we hope that more crashes can be avoided. And yes. So that was it from me, and I thank you very much. I'm very happy to share my research with you, and yes, I hope I can answer the question after the other two talks.
Thank you, Katja. That's really great. A really good overview of the data, the different crash risks between conventional bicycles and pedelecs, because I think countries where older people have always cycled, they're now seeing more older people riding e-bikes. So it's really important to keep that in mind, but also the sort of downward trend in the median age. I thought that was interesting too. It's something I think they're seeing in the low countries as well, that everybody wants an electric bike now.
Yeah.
So we go from cycling to pedestrians. And I'm very pleased to welcome Jenny Eriksson from VTI in Sweden, which is the road transport, let me see, Swedish National Road and Transport Research Institute. Jenny is a statistician, and she's been looking very specifically at the issue of pedestrian falls. Now, as I mentioned earlier, pedestrians falling in the road is not currently part of the EU definition of a road death. But nonetheless, in Sweden, this is still data that they are collecting. And it's important, I think, particularly when we're talking about older pedestrians, to gather this data, because it can have a big impact on this section of the population. So I'm going to give the floor to Jenny, and she's going to present the view from Sweden on pedestrian falls. Thank you, Jenny.
Thank you.
Jenny, we don't hear you so well. I don't know.
Okay. Do you not hear me?
Yes.
Yes. Okay. Yeah. Thanks, Jenny, for the introduction, and thank you for the invitation. First, we need to start with who is a pedestrian, and normally it's walking on foot. But in Sweden, and I don't know how it is in the other countries in Europe, but in Sweden we also include persons in big bikes, skateboards, roller skates, and wheelchairs. And these contribute about 5 to 10% of the accidents. We also need to know a little about the definition, pedestrian falls. It's not defined as a road traffic accident, as Jenny told you before, and because there is no other vehicle involved. But it could involve an interaction with other road users, such as make way, but it will not be a collision. And in Sweden, we have a target to reducing the pedestrian falls, and it's the Vision Zero collaboration group that has decided this target, and it's about to reduce the number of seriously injured pedestrians and falls into road traffic in road traffic by 25% between 2020 and 2040. And this target should be tracked in the same systematic manner as governments in the targets. And you can read more about this in the English report that we have here. We have the link in the presentation. The results that I will present for you is from the Strada Hospital. We call it is a database, and the data collected is collected and with all the A&Es in Sweden, all the units in Sweden are collected and reported to this database. And this includes self-reported data in like a survey and the patients get, and as well as data from the medical records. And the injury severity, how to classify it, it's by the healthcare professionals using the AIS codes. But in Sweden, we have a definition differ a little about the seriously injured. In here in Sweden, we have it's defined as someone who has suffered at least a 1% permanent medical impairment as a result of a road traffic accident. And this is based on AIS codes. And you can get more of how to calculate it in the scientific article.
Jenny, sorry, can I just interrupt? Can I just ask you to put your microphone a bit closer, because sometimes we lose what you're saying.
Okay, Is it better now?
Yes.
Okay, I hold the microphone. The seriously injured road users, I have, it's, last year it was 37,000 registered road users in Stava Hospital from the IMEs, and of those there were 7,600 seriously injured pedestrian falls, and pedestrian falls are included in this. And the distribution is that the main are pedestrians. It's about 43%. And to compare with police reported as they defined the seriously injured road users, it's about 11%. So it's quite a different share. And this from police, it's almost crashes with cars, pedestrians who have collision cars. What's the type of accident? Well, it's almost about the pedestrian falls. It's like 93%, followed by collisions with both vehicles, with 5%, and so on. So it's really, it's almost all. And first we have to look at the age distribution of pedestrian falls. And as you can see here, we have age in 1-year classes, and the elderly are seriously injured. It's quite a lot of them, but there are still many who are younger than 65 years. So perhaps it's not an elderly problem. It's also what you say in the middle age problem. I have divided it into gender, and the females are totally overrepresented. And it starts at what you say about 40 or 15 over there. And we have some thoughts about why are the women so overrepresented, and what we think that we see that women walk more than men, but not so much that it could explain the major difference. And women can be affected by osteoporosis more than men, and women might use high heel shoes. I think men are doing that. But the fashion now is to wear sneakers, so perhaps it isn't an issue. And the women have the thin shoe soles during the winter and probably sleeping more. But this is not. But this is only speculations. We haven't done any research. This, but we hopefully we will have shoes. The three common causes by the pedestrian fall in Sweden, we have winter with snow, and it's a lot of the causes is mostly about slippery road surface due to ice and snow. But it's also uneven surface or potholes, it's 70%, and stumble on curb, it's about 10%. Often you think that pedestrians falls is on the sidewalk or pedestrian path, and well, it's the common place to fall, but it's also in street or road, and it's in the parking lot or areas. I think it's most. You're getting out of the car, it's slippery, it's ice, and then you fall. So perhaps the largest risk during a party is one to and from the car. And then you have the intersection then and square and bus and transit houses. Where on the body do we have injuries? I have 3 different columns. The first one is all injuries that have been registered at the hospitals. And then we have the serious injuries and EU standard, which is AISC+. And it's some differences. If we start with serious injuries, it's mostly on the upper extremity, it's arm and shoulder. And then you have the lower extremity and whole wrist, about 46%. And look at all the injuries, we can see the upper extremities is common, and the external skin and internal injuries, I think it's most perhaps it's the wounds that need to be taken care of. And the European standard, there is about half is about the lower extremity and pelvis, and I think mostly it's fracture on hip or limb. We also have some information about pedestrian falls in where they get fatally injured. And this is not included in the official statistics. But in the Strada Hospital database, we have 61 registered fatally injured pedestrians during the period 2014-2019. And at least 29 of those were due to the accident, but we really don't know because they don't do any in-depth studies of this. And it's both elderly, and the common thing is falling and hit the head. And some of them hitting the head against the curb or when slipping on ice or snow. And this 61 should be compared to the 220 pedestrians who were involved in collisions in this area. So we'll sum up the most common is pedestrian falls, and more than 90% was caused due to a fall, and women 54 or perhaps 50+ are overrepresented. And elderly, yes, but also in working age. And if you don't measure, then you don't know and it's a quite big message. And I also have to see how much costs, and the costs for the pedestrian falls in traffic environment are estimated to 3.5 billion euros per year. So it's not a small cost, it's a big cost. And what are the actions to reduce the number of injured? In Sweden, we need to talk about better winter maintenance. It sounds good, but how do we manage to do that? The pedestrian walks everywhere, and what is the most effective way to do it? Is I think it's a good research question, but we don't have the answer. We also need to have good evenness on the surface, but what is good evenness? We have a research project for the circuit part at ETI that will answer this question, but its results will be for cyclists, and perhaps pedestrians have other demands. And for the pedestrians themselves, it could be using spike on shoes or feather shoe soles. And in Sweden, there's ongoing research according to testing with the winter shoes or shoes soles. this will be successful, we hopefully have an international standard for use. So thanks for your attention, and I have a report that is mostly in Swedish, but I have an English summary.
Thank you very much, Jenny. Again, some really interesting data there. I liked your message about if you don't measure, you don't know. And it's true, that difference between the police statistics and the statistics involving the pedestrian falls is really stark. And I think it's a message that ETSC also makes, we also make in our report. So really grateful to you for sharing that with us today. So we're going to have one more presentation, but there is an option obviously to ask questions of Jenny and Katja after Rachel has spoken. So please do give us your questions in the Q&A box. But now I give the floor to Rachel Birrell. She is the Bus Safety Development Manager at Transport for London, which is the body responsible, obviously, for most of London's transport network. And Rachel is going to talk to us about work that they've been doing there, looking at the safety of buses. I think for all road users, bus people inside, passengers inside, road users outside the bus, also training, I think, for the drivers. It's an example we also included in our report. So we're really pleased that Rachel could be with us today to tell us about the work they've been doing. Rachel, I give the floor to you. Thank you.
Thank you. I shall just get my presentation. Okay, is that showing okay for everybody?
Perfect, lovely.
Okay, great, thank you. Yes, I work in the bus safety development team, which is part of bus operations at Transport for London. I'm going to provide an overview of our bus safety programme. It obviously is encompassing all safety for passengers and people outside the bus, but I'll focus on specific measures that we have in the programme that that help to reduce stress and serious injuries among older people. So just as a brief bit of background, TfL has adopted the a Vision Zero, and the Mayor's Transport Strategy sets out targets that no one should be killed or seriously injured on London's roads by 2041. For London's buses, we also have two interim targets. So we had a 2022 target for a 70% reduction in people killed or seriously injured in or by a bus. And then in 2030, we have a target for no one to be killed in or by a London bus. Just to clarify as well, by casualties involving a bus, that's whether or not the bus is the primary cause or contributory factor. So this just encompasses all collisions involving a bus or people inside the bus. We have a bus safety strategy, which we recently published in September. And this provides a lot of detail basically on what we've been doing since 2017 when the programme was developed, and our future actions and measures to ensure that we meet these targets. So just as to provide an overview of the challenge that we have in London. So the particular challenges for people walking, cycling and using a motorcycle, they're most at risk of being killed or seriously injured. This slide just provides a snapshot of the bus involved collisions in 2022. So sadly, 9 people were killed by on or by a bus in 2022, and that included 4 pedestrians, 2 people cycling, 2 bus passengers and 1 car driver. We also have onboard injuries on the bus, which, although they're not part of our Vision Zero targets, we do have other targets to reduce these injuries. These injuries include slight injuries as well, but they're obviously a very important part of the programme as well that we are working more now to reduce. In terms of just the long-term progress that we've had for people killed or seriously injured on or by a bus, buses are the safest mode to travel on London's roads. They carry more people than any other public transport mode in London, and we've got fewer than 0.68 people killed or seriously injured per million bus miles between 2017 and 2021. So we have seen a decrease of 54% in the number of people killed or seriously injured against our baseline, which is 2005, 2009. And this is compared to an overall reduction on London's roads to 38%. We obviously saw a big drop during the pandemic, and we did, during the pandemic, I guess, meet our 70% target reduction, but then we have seen an increase then since 2022 in particular, and this is mainly due to an increase in the number of people killed or injured who are cycling and also bus passengers. So we are working to understand this increase more and address that at the moment. This next slide just then provides an overview of our trends for passenger slips, trips and falls. So this is all incidences. This doesn't just include, this includes slight injuries as well. So as I mentioned, a reduction in passenger slight injuries is particularly important for our vulnerable customers. So if you're an older passenger or disabled and you have a slight injury on a bus, that may disproportionately affect your confidence to travel. So this is a really important area for us to also address. Our research also shows that older people, as well as women and children, have a higher risk of suffering an injury on board a bus. And in terms of the risk outside the bus, our research also shows that those aged 70 years and older are at a higher risk of a fatal or serious injury while walking. So this is an area that we will be undertaking more research to understand the risks in more detail, because we also need to understand that bus usage is higher also among Londoners who are aged 65 and over. And with 78% of Londoners aged 65 to 79 using the bus at least once a week. This does decrease for people that are aged 80 and over, but given that it's a high number of passengers that are using the bus and the increased risk, is an area that we are looking at in more detail. So I will cover that in a bit more detail when I go over our work stream that we have on passenger injuries. So just as an overview of our bus safety programme. So we established the bus safety programme in 2016. And as I mentioned, this is to reduce all numbers of people killed or seriously injured. And we cover a range of areas in line with Vision Zero. So we look at safe vehicles, which is what I'm going to be covering in a bit more detail in the slides ahead. And this is to reduce the danger posed by buses, and it's around the standards that we set for new buses entering the bus fleet in London, and also retrofitting existing buses in the bus fleet. Safe speeds, obviously the speed is one of the most important aspects on whether a collision will occur, and then the effects of that collision. So we have a programme of works to reduce speed limits across London, and we also have technology on buses which ensures buses cannot go over that posted speed limit. Safe streets, so this is a wider area of work for Transport for London and London boroughs, but this is around designing streets so they are forgiving of mistakes and encourage sustainable and active travel. Safe behaviours, so I will cover this as well in a tiny bit of detail for the passenger injuries, but we work with bus operators very closely to look at bus driver training. We have a health and wellbeing programme and fatigue programme as well, which looks at bus driver training and how we can ensure that the drivers are safe, and then also around communication with bus passengers. And then lastly, the post-collision learning. So this is around monitoring progress and also providing support for victims and families. So as I mentioned, we have a bus safety standard which sets out what our requirements are for new buses entering service in London. So the first requirements were set out in 2019, and then the next set of requirements were 2021, and then we've got new requirements coming in 2024. There are currently 25 measures as in the bus safety standard, and this diagram just shows the kind of 4 categories that each of those fit into. So driver assist is to help a driver avoid or mitigate a severity of incidences, and I'll be just talking through intelligent speed assistance. I'll work on direct and indirect vision as two areas of this. Occupant protection, so that's obviously very important for reducing the severity of passenger injuries and the likelihood of them occurring. Partner assist, so that's for helping other road users outside the bus. So I'll be just talking through our acoustic vehicle alerting system that we've implemented. And then finally, partner assist. So one new area that's coming in next year is increased requirements around the frontal crash worthiness of buses. So this is changes to the front end of the bus, so that if a collision occurs, the impact is much reduced. So one of the areas in our bus safety standard is the acoustic vehicle alerting system. Or AVAS. So AVAS provides an artificial sound for quiet running buses. So this is for electric, hydrogen and hybrid buses, which are an increasing part and will continue to be an increasing part of the bus fleet in London. And as they don't have an engine sound, there's a particular issue for vulnerable road users. So we worked very closely with acoustic sound engineers. We did a lot of stakeholder engagement to develop a unique urban bus sound. So this is so that the sound was distinguishable over the city like background noise. We've also made sure the sound levels are responsive to what the background sound levels are. So on a quiet residential road, the volume is reduced. Oxford Street at midday will be obviously a higher sound setting. We did a lot of engagement with different stakeholder groups, so with blind and visually impaired people, elderly people as well, walking and cycling groups, and to really get feedback on the sound to make sure that it was distinguishable. This measure we brought in prior to the regulatory requirements, and we've exceeded it with the sound that we've developed. This is obviously one measure that I think is a particular benefit for more elderly people, so they can hear the bus. They may be less likely to notice the quiet running bus. So we've worked very hard to try and make sure that sound is as effective as possible. And that's been a requirement for new buses since 2019. And we are also retrofitting that to quiet running buses as well. Another measure is direct and indirect vision. So obviously the driver's ability to respond to an imminent collision is dependent on how well they can see. So direct vision is concerned with the driver's sight line, whereas indirect vision aims to address any blind spots. So compared to heavy goods vehicles, obviously buses have a better direct vision because they have larger windows. However, through our work, we identified that there were blind spots that remained, and also the regulatory requirements were less demanding than for HGVs. So we've set out stronger requirements for direct and indirect vision for buses, and as part of this we introduced blind spot mirrors in 2019. You can just see on the image there, it's an additional mirror that reduces that blind spot at the lower end of the bus. And then in 2021 we've required camera monitoring systems. So this actually means we can take off the mirrors and provide a camera, which reduces, which significantly reduces all blind spots for the driver then. And we are at the moment also retrofitting camera monitoring systems to, or plan to retrofit camera monitoring systems to existing buses in the fleet as well. As I mentioned, safe speeds is a very important part of the bus safety programme. So we have a programme rolling out 20-mile-an-hour speed limits in London. More than half of London's roads are currently subject to 20-mile-an-hour speed limits, and by 2024 more than 220 kilometres of the TfL road network will be 20 miles an hour. In terms of the technology on buses, we've introduced intelligent speed assistance, which has been a requirement for new buses since 2019. This limits a bus to its to the posted speed limit. So if it's on a 20-mile-an-hour road, the bus will not be able to exceed that limit. This is obviously very important in reducing the impact of any collision and also the likelihood of any collision. And then safe vehicles. So this is around requirements that we have for improving occupant-friendly interiors, so which reduce the impact of any fall that a passenger may have on the bus. So we introduced measures in 2021. So these are requirements around the staircase, the seat positions, the handrail construction and positioning, and also introducing guards for the seats that sit behind the wheelchair and middle door, to make sure there's better restraint for passengers in those seats. We're bringing in stronger requirements that are coming in next year. So this includes things like high back seats, removing the middle back seat at the back of the bus. And these all aim to reduce serious and fatal injuries for customer injuries, which is an increasing part of our projected injuries. So it's an area that we're working hard to reduce. And then a bit more on customer injuries. So obviously slips, trips and falls, they're not a new phenomenon. There's been work and passenger communications ongoing. This is two posters on this slide are from the London Transport Museum, encouraging passengers to hold on. So it's obviously an area that's been looked at for many years, but we've recently introduced a new work stream focused on bus customer injuries. So reducing passenger injuries, as I mentioned, is also particularly important for older passengers. They're more likely to be seriously injured and more likely to affect their confidence to travel. So it's a really important part that we're addressing. So we've recently so in July 2023, we launched a Bus Safety Innovation Challenge. This is to trial new solutions to reduce bus customer injuries. So we're going to fund new technologies and new ideas on buses as to what we could implement across the fleet to reduce injuries. We're also research is also underway to look at the way how we can expose risks to bus passengers. So we're going to be looking in a bit more detail of the demographics of our bus passengers and the risk involved, and then also looking for human factor experts to research and how we could influence bus customer behaviour. As I mentioned as well, we also, TfL and bus operators provide ongoing training for bus drivers, as well as specific training. For example, we had Destination Zero training that was completed last year. We've recently developed an equality, diversity and inclusion course for bus drivers, and this is helping to increase drivers' awareness and empathy with customers so that they have knowledge and skills to deliver an inclusive service. So, for example, ensuring that bus drivers wait for elderly passengers to sit down before departing, as a reminder that that should be and why that's important. We've also been working with disability groups to develop changes to our on-bus access ramp, as well as ongoing communication there. So as I mentioned, the next set of requirements for our bus safety standard that we're developing will be introduced in 2027, and then we'll have requirements every 3 years from there. So we're undertaking a lot of research now to inform what should be this next set of requirements. Reducing passenger injuries is a key part, will be a key part of these next set of requirements. And we'll also be looking in a bit more detail about demographics and risks, including the risks for older people as well. So it's actually been a really interesting presentations and discussions today. Thank you.
Thank you, Rachel. Really great to hear what you're doing. Nice also to see that you're measuring it, going back to what Jenny was saying, if you don't measure, you don't know. So nice to see that you're measuring it, you've got targets. And yeah, we look forward to the research you're going to fund into new technologies and how they can improve the safety. So we've got a little bit of time left for some questions. So hopefully we've got Jenny, Katja and Rachel back on the screen. We've got a question in via the Q&A box for you, Rachel, seeing as you've just spoken about the ISA system that you've got. And is this limit determined by a map or on cameras? And did you have any statistics about the impact of it? And I'd also like to add a little question for myself about what the sort of drivers feel about it as well, if you had anything on that. So anything that you've got about your ISA system?
Yeah, so the ISA system is linked to a digital speed limit map that we have of London, which is updated with the latest speed limits for London. So, and it links to this. So if the bus is driving on a particular road, the ISA system will know that that's limited to 20 and limits the bus from accelerating beyond that point. What was the other question? Sorry, the second one.
Have you had any feedback from the drivers about how they feel about it?
So in terms of monitoring, so in terms of the bus safety standard generally in monitoring, because we brought the measures in 2019, we're now starting to look at the benefits and to understand what the impact's been. And that's actually really important to inform our next set of requirements. We just needed to make sure that we've got enough buses, basically, because the technology rolls out as new buses enter the fleet. So that's an area that we're looking at. Feedback from buses, I think the only thing, well, there's one of the main things we had to implement was we gave operators the option of putting a poster at the back of a bus to note that, so that other drivers were aware that the bus was speed limited. I mean, the wider benefit is that if the bus is going at 20, that obviously means that all other traffic behind it is also going at that speed. But that was also, we were getting some feedback that was causing frustration. So we put the poster there so that other road users were aware that the bus driver, is limited to the speed limit.
Yeah, that's a good to know the consequences. Katja, I wanted to ask you a question about the pedelectors collisions, and you mentioned that many of them were single vehicle collisions without another vehicle involved. So I'm just wondering, do you know anything about the nature of those collisions that could maybe help people? Is it about the infrastructure that could changes be made there? Do you know anything about what the nature of those single vehicle collisions is?
Yes, there are several studies who investigated single vehicle collisions and they found that there are several causes, especially due to elderly riders. They found that they have specific age-related handling problems with e-bikes, which means that they lost control because they cannot handle the higher speed, the higher weight of an e-bike. That's where therefore the training would be a very good measure to help them. And of course, it's also the infrastructure. Sometimes it's a slippery road. Sometimes there are tram tracks on the road. This is a very specific type of accident, especially in cities, which is also problematic for conventional cyclists. And yes, for e-bikes, it's or for e-bike rider, it's harder to maintain the control of the vehicle.
Yeah, so it's good that training, as you say, will hopefully address some of these issues to tell people that when they're buying an e-bike, that these factors could be.
Yes, that they learn to brake properly with an e-bike. This also causes single accidents. Yes. They brake too hard and then they fall over.
Yeah, okay. Thank you. Jenny, if I could ask you about if you have, so it's great Sweden is measuring these pedestrian falls. This is something that we really welcome. But I'm just wondering what impact this data has and what different places, what Sweden is doing to address this issue and how it's using that knowledge that you have there to remedy the situation.
Well, firstly, I think that it's a lot of talk and actions in Sweden. I'm sorry for that, but pedestrians are not prioritized in the traffic safety issues, and definitely not in the main that it is. But some of them is in many municipalities they have a city center with many pedestrians, and they use the heated payments, and that action should certainly contribute to many small falls during the winter time. So, well, what can I say? We work on it.
I'm sorry to hear that. It's especially if they have a target. I think they will have to take some action. I think if they are to meet their target. But we had some examples in our report, I think, from towns who maybe are choosing to prioritize winter clearing of things. So I think there is some action happening, but it's perhaps
yes, some of the people prioritize the pedestrians and also the cyclists.
Yeah.
Say that, but I want them to do more.
We can always do more.
Yeah.
True. Listen, thank you very much. I'm afraid we've come to 12:30, so we've come to the end of our event today. It's been a really great overview, I think, of all the factors in older road user safety. There's a lot of data out there. Obviously, there's a lot of knowledge. I hope that this event has in some way spread that data out, and then hopefully we see some action building on what we already know. So I just wanted to thank all our speakers today for taking the time to share their knowledge with us. And as I said, they've kindly all agreed that the presentations can be put on our website, so we will put them on our website in the coming days. And yeah, thank you very much, and I hope everybody has a nice day. Thank you very much. Bye-bye.